ribadito ancora una volta l'importanza che ha la modifica dell'attività fisica e contemporaneamente che questo implemento dell'attività fisica sia un'attività fisica protetta per quanto riguarda il piede del diabetico. Questo tema viene ulteriormente approfondito dal professor Robert Frykberg. Avremo il piacere, faccio un po' di pubblicità, di ascoltare il professor Frykberg anche domani mattina nella sua lezione sulle osteomieliti, e quindi per adesso però sentiamo il professor Frykberg sull'attività fisica protetta. Prego.
Buongiorno, pleasure to be here amongst all my Italian friends and even an English one, even though he's not wearing a tie. Okay. I would just like to introduce the subject of biomechanics and the importance of pressure reduction and appropriate footwear as part of our prevention program for the diabetic foot. If I can get this to work. There we go. We know that the diabetic foot is a very complicated system, and the high-risk foot involves not just neuropathy or sensory neuropathy, but also motor neuropathy and autonomic neuropathy. Very important components in that high-risk foot. Also, we recognize the role of vascular disease, both microvascular as well as macrovascular disease, which sets up the system for a high-risk foot, to which we apply trauma, and that trauma is all too frequently inappropriate footwear due to tight shoes or something's going on here. Due to tight shoes or inappropriate correction of deformity. Can we go back, please? This is not working properly. Okay. As Dr. Bolton had just mentioned, a very important study published by Gail Ryber, also with Dr. Bolton as a co-author, was published in 1999 and used the Rothman model for causal sequences leading to, in this case, ulceration. And in that important study, it was found that the three most common component causes in those patients leading to ulceration were, of course, neuropathy, but also, importantly, deformity and subsequent trauma. So deformity in the neuropathic patient becomes a critically important component in that pathway leading to ulceration, and we must avoid trauma to those deformities and thereby provide for footwear protection or protective insoles which can reduce plantar pressures, also a significant form of trauma. So we know that there is altered biomechanics in diabetes, and these are usually a consequence of pre-existing sensory and motor neuropathy. We need to recognize this. Although many patients can have idiopathic deformities at the onset of diabetes, subsequent deformities come as a result of neuropathy. This can also lead to altered gait patterns, unsteady gait, as we saw from the presentation this morning, leading to increased plantar pressures for longer than normal pressure time intervals. Very, very important. The combination of foot deformity and neuropathy, as we said, increases the risk for ulceration. And we also compound this with the important role of limited joint mobility and higher plantar pressures as a result of this. Also has been shown to be associated with increased prevalence of foot ulceration. So if we look at all factors combined, we can see within the diabetic patient that neuropathy can lead to abnormal mechanics and higher pressures, structural deformities, which may or may not be due to the diabetic neuropathy, leads to abnormal biomechanics and pressures. Gait abnormalities the same, and even limited joint mobility. So this diabetic neuropathic foot is a high-risk foot that is prone to ulceration just due to abnormal biomechanics, leading to increased plantar foot pressures. Common foot deformities in the diabetic foot are obviously camera toes or claw toes, bunions, hallux valgus, prominent metatarsal heads, the classic Charcot arthropathy, as we can see here. Partial foot amputations as a result of our limb salvage efforts also are important biomechanical deformities that can lead to high pressures and ulceration. Equinus deformity, a consequence of chronic long-term motor neuropathy, can lead to higher foot pressures, especially on the forefoot. And of course, we have crural atrophy as a result of motor neuropathy leading to foot drop. So these are all very important deformities that we must be able to recognize and properly treat in our diabetic patients. Now this paper from Edgar Peters just showed the progressive risk of ulceration as we go from in diabetic patients without neuropathy, group 0, this is the International Working Group foot classification, from no neuropathy to neuropathy with PVD, PAD, and or deformity, and those with a history of ulceration and amputations. And as we can see, the risk of subsequent ulceration dramatically increases in those patients with neuropathy, and especially those with a history of prior ulceration and prior amputation. Any risk factor for ulceration is almost always a risk factor for amputation. Once a patient has had an ulceration or an amputation, they are very high risk, the highest risk for developing those problems once again, and that is shown in this study here. Multiple studies for the last almost 2 decades have shown the role of high plantar pressures leading to diabetic foot ulceration, and they're consistently detected in patients with neuropathy, going back many, many years, excuse me once again. Multiple studies showing high plantar foot pressures in neuropathic patients, also correlated with limited joint mobility, plantar tissue thickness, and plantar fascia thickness. This is also shown by a group here in Italy. It's been a constant risk factor for ulceration in any and all studies that have looked for plantar pressures as a putative risk factor for ulceration. And even certain studies have shown that racial variations are evident in terms of the risk for ulceration and associated plantar pressures. So what this means is it's critically important for us to recognize the role of plantar foot pressures related to deformity and the need to offload those deformities to reduce the pressures sustained by the plantar surface of the foot. So how does this implicate our strategies for managing? Well, recognizing the very important role of deformity and high plantar pressures, therapeutic footwear becomes a critical factor in our prevention program. So with our therapeutic shoes, we recognize that there are extra depth versus custom fabricated shoes for the severely deformed feet. Some early work was done on diabetic socks for protection and pressure reduction, but the problem with this strategy was that the shoes often did not have enough room to allow for the increased thickness of these stockings, so we had to be very careful about that. And of course, also, the other important therapeutic strategy in terms of footwear are pressure or shear reducing insoles, usually in combination with appropriate therapeutic diabetic footwear. And we can have multi-density, off-the-shelf types of insoles. Again, I'm pressing the wrong button, I'm sorry. Off-the-shelf type of inserts, or we can have custom-made types of inserts, all with the function of trying to reduce plantar pressures under those deformities. And now we even have pressure and shear reducing insoles, although the shear reducing insoles don't seem to reduce pressures, vertical pressures anymore than customary types of insoles. They can reduce shear pressure, which is also considered to be an important component cause in the development of ulceration. Aside from the prefabricated types of insoles, we also have custom fabricated insoles that are made of a direct mold of the patient's feet. Now, these are especially important for patients with prior histories of ulceration or with significant deformities that are more just need to focus on prescribing these options for patients, especially those with neuropathy and especially those with prior histories of ulceration. So, as part of our overall diabetes management with an eye towards preventing these important complications, we know, of course, that good metabolic control is critical, insulin, oral agents, etc., proper diet, and of course, very important component in good metabolic control is physical activity and exercise. But we recognize that patients engaging in strenuous physical activities or exercises often have their feet at risk, and we need to make sure that we prevent shoe-related trauma to these high-risk feet as they're trying to control their diabetes better. It also includes appropriate self-care practices, of course, with self-monitoring of blood glucose, but also daily foot inspection, daily foot care, as well as proper footwear. You all have patients who wear terrible shoes or very inappropriate shoes. Where I live, the patients don't wear their proper footwear when they go outside. They can develop second or third degree burns, especially in the summer where it gets extremely hot in Phoenix, Arizona. Also, we recognize the role of education. So these are all important avenues to follow as we practice our prevention programs. But education is not only of patients, it's of the providers, ourselves as well, so we're well aware of the important components in proper care of diabetic patients, especially those with high-risk disease. So this leads us to our